Welcome to this lecture on ulnar neuropathies at the elbow. We're going to focus on the neuropathies in this region and especially talk about the utility of electrodiagnostic methods. We're going to talk, however, about other aspects as well. I will start with the anatomy, in particular at the elbow, discuss the different types of ulnar neuropathies we see at the elbow. How do we go about diagnosing them? Various methods we can use, the history, clinical findings, electrophysiology, imaging. And finally, I will talk a little bit about the treatment and the outcome of the neuropathies, and at the end there will be a typical patient case. If we look at various kinds of focal neuropathies we see in an electrodiagnostic lab, ulnar nerve neuropathies are very high on the list, usually number 3. Here we see from statistics from the University Hospital in my hometown. We see that ulnar neuropathy is the 3rd most common neuropathy we see. In the literature, ulnar neuropathies are quite confusing, partly because of the terminology, but also about what is causing them. It's not really that clear. Very often we talk about ulnar nerve entrapments. Entrapment, that is a chronic neuropathy caused by anatomical causes. But many of the ulnar neuropathies are not chronic. They are fairly acute or subacute. Often we talk about cubital tunnel syndrome. There's tardy ulnar palsy. The terminology is not really that clear, and there's not enough differentiation between the different causes we see in these neuropathies. Where exactly in the elbow region is the neuropathy localized? Is it retroepicondylar? Is it in the cubital tunnel, or is it more diffuse all along in the elbow? And above all, the most important thing is to try to differentiate between different causes that are causing the ulnar neuropathies. The ulnar nerve is leaving the plexus brachialis from the medial cord, so it gets innervation from the spinal levels C8 and TH1. In the upper arm, it passes along with the artery and the median nerve, and in the lower part of the upper arm, it will separate and pass behind the medial epicondyle into the forearm. And in the hand, it will finally branch into the distal branches just above the elbow, about 5 to 7 centimeters above the elbow. The ulnar nerve will have a dorsal branch, which is a purely sensory nerve innervating the dorsal side of the hand. And it continues down into the wrist, where it has a deep branch innervating the muscles, and a superficial branch which will innervate the sensation to the little finger, both sides, both the medial and lateral side, and to the medial side of the ring finger as well. Here we see the dorsal branch of the ulnar nerve. You can see that it is a little bit variable, and it's not only innervating the ring finger, but very often also it will send a branch to the middle finger. A small proportion of people totally lack the dorsal branch, so the radial nerve will innervate the entire dorsal side of the hand. About 1 to 2% of the population lacks this sensory branch. If we look at the branching of the nerve and the innervation of the muscles, there's an excellent book by Sidney Sunderland, Nerves and Nerve Injuries. Sunderland was a neurosurgeon active during World War II, and he dissected quite a lot of made a lot of anatomical dissections of the nerves and described carefully how the branches to different muscles pass. And here we see how the ulnar nerve innervates the muscles in the forearm. We see the jotted line here is the medial epicondyle, and you see how branches to different muscles, flexor carpi ulnaris, flexor digitorum profundus, varies from one subject to the other. In a similar way, the branching to the hand muscles is quite variable and individual. The order of innervation is fairly straightforward. In the forearm, flexor carpi ulnaris, flexor digitorum profundus receive their innervation, and in the hand, the deep ulnar branch will innervate the abductor digiti minimi is the first muscle, and at the end point, the first dorsal interosseous and adductor pollicis and flexor pollicis brevis. If we look at the ulnar nerve closer at the elbow region, you see that the nerve comes behind the medial epicondyle and it goes underneath the aponeurosis of the flexor carpi ulnaris muscle. This aponeurosis is often called Osborn's ligament as well. And here it passes into the forearm. Around the elbow, the ulnar nerve is often covered with a small muscle called epitrochleoanconeus. It's present in about 1/4 of people. The clinical significance of this muscle is not really clear. No neuropathies have been assigned to this muscle. And it's not possible to identify the muscle clinically by palpation. Probably you could see it with ultrasound. In the elbow, the ulnar nerve may luxate, and luxation occurs in about 15% of the population, and there's no proven negative clinical significance to this. Here we see how the luxation can be demonstrated with ultrasound. You can also clinically feel the ulnar nerve come around the medial epicondyle clinically if you palpate the ulnar groove when you flex the forearm. Actually, it's quite interesting that ulnar nerve luxation may be a protective factor against ulnar neuropathy, so it's not necessarily a negative feature. Ulnar neuropathies at the elbow are quite common. They occur about 40 patients per 100,000 inhabitants per year. It's more common in men than in women, about twice as common in men than in women. And usually ulnar neuropathies are on the non-dominant hand. In opposition to the carpal tunnel syndrome, which is usually more prominent in the dominant hand. Predisposing factors are obesity and arthrosis of the elbow. If we look at the anatomical features here, we have the cubital tunnel. The cubital tunnel is formed by the aponeurosis of the flexor carpi ulnaris muscle and the ulnar collateral ligaments to the elbow joint. So it's a fairly tight structure, and if we look at it in the elbow extended position, the flexor ligament is relaxed, and when you flex the elbow, you can see that the tunnel diameter is decreased and the nerve is compressed. And here we see the relationship between flexion angle and the cross-sectional area of the cubital tunnel and the ulnar nerve. You can see that to the right there, the area is significantly smaller when you flex the elbow. and also the pressure in the cubital tunnel increases when the elbow flexion goes beyond 90 degrees. The ulnar nerve is also stretched when you flex the elbow, both proximally and distally. So a number of things happen when we flex the elbow. The nerve is subject to compression and it's a little bit stretched. So no wonder that we have ulnar neuropathies in this region. A number of years ago, Neary, Ochoa and Gilliatt, they looked at cadavers, 12 subjects, and they looked at the ulnar nerve at the elbow, and they found in 5 subjects, they found anatomical changes that are similar to those we see in focal neuropathies. And these were all healthy subjects, so they had no known ulnar neuropathy during their lifetime. So obviously there is a slight wear and tear of the ulnar nerve at the elbow in most people. If we look at the causes of ulnar neuropathy at the elbow, often in studies about ulnar neuropathies at the elbow, they are all lumped together, which is not the right way to go about it. The way I see ulnar neuropathies at the elbow is you have to try to differentiate different causes. In my practice, the most common kind of ulnar neuropathy at the elbow is caused by temporary compression. That may be a single prolonged episode or repeated episodes that accumulate and cause a neuropathy. About 90% of the ulnar neuropathies are caused by temporary compression. We do see chronic entrapment in this region, but it's quite rare. A third kind is tardy ulnar palsy. It's a diffuse compression caused by arthrosis. So there's a deformity of the elbow and the ulnar groove is deformed. That may be caused also by a supracondylar humerus fracture or just pure arthrosis or rheumatoid arthritis. This is also quite common. About 5% of the ulnar neuropathies represent this. Sometimes we see traumatic ulnar neuropathies at the elbow, in particular if we have an elbow luxation. Both the median and the ulnar nerve are affected when you have a luxation of the elbow. And in association with surgery, in particular elbow arthroplasty, you can see ulnar neuropathies as well. Let's take a closer look at the temporary compression. It's often acute, sometimes subacute, starting within weeks or months. Very common, more often men and women, and the non-dominant hand is more often affected. It's important to note that there is no pain associated with this. The symptoms are quite clear-cut. Numbness of digits 4 and 5. Also the dorsal side of the hand is numb. There is weakness of the little finger flexion. The distal phalanx of the digit 5 is weak in flexion. And when you spread and abduct the abductor digiti minimi, there is weakness as well. Various situations where we can cause this compression is computers nowadays. My lovely wife here is sitting at the computer and leaning on her left ulnar nerve. Watching TV on the sofa may be dangerous. Reading and the mobile phone as well. So there are a number of situations where we get a compression of the ulnar nerve at the elbow in our everyday life. Neurophysiologically, we see slowing of the conduction velocity across the elbow, in particular the motor conduction. We don't measure as often the sensory conduction across the elbow as we measure the motor. There may be a conduction block if we see the patient early on after the onset of the symptoms. If we do short segment studies, the abnormality will be proximal to the medial epicondyle, above 10 to 20 millimeters above the medial epicondyle. That is proximal to the cubital tunnel. The sensory responses may be reduced if we have an axonal involvement, and the sensory response of the dorsal branch will also be decreased. And we see EMG abnormalities in the muscles innervated by the ulnar nerve if we have axonal involvement. An illustrative typical patient here, a 45-year-old previously healthy woman. She woke up on a Sunday morning with numbness of digits 4 and 5, slight clumsiness of the fingers, no pain, and she's referred for EMG by her general practitioner, who asks whether there is ulnar entrapment at the elbow. Clinical findings were quite unremarkable. Muscle strength didn't show really a significant side difference with the right side. Here we see the sensory neurography of the ulnar nerve. You can see that the response amplitudes from the little finger and ring finger and the palm to wrist are quite normal, and the conduction velocity is normal. Motor conduction velocity in the forearm is normal, but you see that there is a clear conduction block. The amplitude decreases clearly when we go from the below elbow segment to the above elbow segment. You see that there's a clear-cut amplitude reduction, 20% conduction block here. If we do a short segment study, you will see that the amplitude is very stable until we come across the above the medial epicondyle, and here you see again the conduction block and delay very clearly. EMG showed no abnormalities in the muscles studied, so this is a very slight ulnar neuropathy at the elbow, mainly a conduction block, and eventually the symptoms cleared within a few months after the onset. It was only a slight demyelination in this case. Then we have a group of patients that come to us because they have ulnar numbness only at night, never during the daytime, but just at night. And we sleep in all kinds of funny positions, and very often with extreme flexion of the elbow in various positions. And this gentleman, he will probably have numbness of both hands, both ulnar side of the hands. And in these patients, we rarely see any neurophysiological abnormalities. It's probably caused by temporary compression, and when the compression is released, the nerve recovers and doesn't leave any clear-cut neurophysiological abnormalities. So here is important just to educate the patient about the cause of the numbness, so they don't keep their arms statically flexed during the night. Then we have a group of ulnar neuropathies that are perioperative. Sometimes before surgery or during surgery, post-operative period, or the convalescent period at home. There's an interesting study from the Mayo Clinic where they looked at more than 1 million operations, and they found ulnar neuropathies lasting longer than 3 months in 0.2% of the patients. In about 9% they were bilateral, and most people made a fairly good recovery. 53% were symptom-free after surgery. And the risk factors in their study was more common in men than women, and extreme obesity and very lean persons were at risk as well. And if you were seriously ill and your hospital stay lasted longer than 2 weeks, you were also at risk. And here we see, when did the ulnar neuropathy start? Most ulnar neuropathy started in the period after surgery, in the post-anesthetic recovery unit or during day 1, 2, or 3, or 4. So the patients were probably obtunded, maybe they had sedatives, and were lying with their elbows flexed for prolonged times. Chronic entrapment neuropathies at the elbow, they do occur, and Stafford and Feindel were the ones that described this cubital tunnel. And here we do see sometimes entrapments that occur at the aponeurosis of the cubital tunnel here. Here we see a surgical picture of the nerve. Here the nerve dives underneath the flexor retinaculum here. Here it has been cut on the right side. The chronic entrapment is rare, usually occurs in young people with normal elbow. Again, it's painless. Mostly the compressive neuropathies affect the thick myelinated axons much more than the thin unmyelinated axons that mediate pain and temperature sensation. The chronic entrapments usually evolve slowly over a longer period of time, and we don't have any good studies that will give us guidelines whether they should be managed surgically or conservatively. One particular type of ulnar neuropathy, which is very typical, is tardy ulnar palsy. It's related with arthrosis of the elbow, so the elbow is deformed. Usually the patient cannot extend the forearm straight. There will be an angle, 15 to 30 degrees, and when you palpate the ulnar sulcus, you don't feel the sulcus, but it's deformed and not very shallow. And this starts insidiously, very slowly, initially intermittent numbness of the 4th and 5th digits, eventually it becomes more permanent, and as time goes by we will also see involvement of the motor fibers, and we get muscle atrophy. And very often the patients will not come to attention while they still have numbness, but they seek help when they realize that they are losing the strength of their hand muscles. And these patients should always be evaluated for surgery. This is a very slow process with tardy ulnar palsy. Usually it evolves over years, and the slow development of the neuropathy means that there is intraneural scarring inside the nerve, which results in it will be difficult for the axons to re-innervate because of the scarring. EMG, usually we don't see a conduction block, but we see demyelination along all segments in the elbow region. The diagnosis. Of course, history is very important. We need to know the handedness, because we know that the non-dominant side is more often affected, men more than women. Occupation, heavy manual work will result in elbow arthrosis, farmers, construction workers. And we have predisposing factors if we have pre-trauma in the elbow region, in particular supracondylar humerus fracture, diabetes, rheumatoid arthritis, polyneuropathy. It's very important when you take history to get an idea how did it start. Very often temporary compression will start fairly acutely, and if it's a very slow involvement, tardy ulnar palsy will develop over years, and usually the patient will not be able to give you a clear-cut onset date when the symptoms started. If it started acutely, I think it's a good idea to try to get an idea, what did you do before all this started? Was there sleep deprivation? You slept more deeply than normal? Was there a party preceding this? And how have the symptoms evolved since the onset? Has there been improvement or has it gotten worse? Epicondyle pain is not caused by ulnar neuropathy at the elbow. Very rarely patients with ulnar neuropathy in this region complain of pain. It's more a slight discomfort. The paresthesias are unpleasant, but it's not painful. Clinical examination. You need to take a look at the hand. Before the COVID pandemic, I would always palpate the first dorsal interosseous of my patients when I shook hands with him, but now that is not what we do, so we have to inspect the hand muscles instead and test the muscles. And we see that with ulnar neuropathy we get a typical claw hand where the little finger and the ring finger are flexed like this. And this is because of the denervation of the lumbrical muscles. The lumbricals are extensors of the fingers, and that's why we see this kind of position. We palpate the ulnar sulcus. We should feel a clear sulcus there. It should be about 5 to 10 millimeters deep. If we have arthrosis, usually there is no clear-cut sulcus at all. When you test the muscle strength, test the abduction of the little finger and the flexion of the distal phalanx of the little finger. If you test sensation, you should use a monofilament or use 2-point discrimination. Other tools, testing it just coarsely, will not give you very reliable information. Personally, I don't spend much time testing the sensation. I will rely more on the patient's report of the paresthesias. Provocative tests are not particularly reliable or useful. Tinel's sign gives you false positives in a high number of situations. Elbow flexion test, maximal elbow flexion for 5 minutes, wrist insupination and extension. It will aggravate the symptoms, but 10% of normal subjects will feel numbness in this position. So it's not very discriminative between healthy subjects and ulnar neuropathy. ANEM has practice parameters for this, and we should measure the ulnar motor neurography across the elbow and forearm to abductor digiti minimi and do ulnar nerve sensory neurography. That is compulsory. And we can also do motor neurography to do the first dorsal interosseous or the flexor carpi ulnaris if the ulnar neuropathy is severe, and EMG is helpful. Here we see a schematic picture of ulnar neuropathy, ulnar motor neurography, and you see that we place the recording electrodes here over the hypothenar region. We can stimulate at the wrist, in the forearm, and we can stimulate below elbow and above elbow. And usually we get nice similar responses from all the stimulation sites. You can see that the amplitude doesn't change very much Here we are stimulating at the wrist, below elbow, above elbow. When you go up to the supraclavicular region, the amplitude drops a little because the distance is much longer here, so we see more dispersion. Very often we see an anomaly where part of the nerve fibers to the ulnar nerve in the hand come from the median nerve in the forearm. It's called Martin-Gruber anomaly, was described in 1763 by a Swedish anatomist from Uppsala, Roland Martin. And here we see the different kinds of Martin-Gruber anomalies. I don't personally try to discriminate between the different types of Martin-Gruber anomalies. You have to keep in mind that there are fibers coming from the median nerve to the ulnar nerve in the forearm. Usually the fibers come through the anterior interosseous branch of the median nerve to the ulnar nerve, and they may innervate various ulnar muscles in the hand. When we do the motor neurography, the anomaly will look like this. Here we are stimulating the ulnar nerve at the wrist, below elbow and above elbow, and you can see that the amplitude drops when we come from the wrist to the below elbow. Comes down from 7.5 to 6.3. 15% reduction in the amplitude here. And when we go above elbow, we don't see any change in the amplitude anymore. So most of the fibers to the ulnar nerve came somewhere in the forearm. Now we keep the recording electrode still over the abductor digiti minimi, but now we stimulate the median nerve. And here we stimulate it at the elbow. And you see we get a small response from the hypothenar eminence here. It's 0.7 millivolts in amplitude. And when we stimulate the median nerve at the wrist, we don't get a response anymore. So we know the axons have disappeared somewhere on the way, and they came to the ulnar nerve, so we can add the 0.7 to the 6.3, and that covers the change in the amplitude in the forearm here. Most of the time when I do ulnar neurography at the elbow, I like the patient to lie on his back and the arm extended above the head. Very often it's helpful to have a pillow there underneath the elbow. The elbow is flexed at a very slight angle of 10 to 15 degrees. This way I have good visibility over the nerve when I do the measurements. Here we are doing short segment studies over the elbow. When we do the short segment study, we mark the midpoint of the medial epicondyle and the distal edge of the olecranon, and we draw a line here which is the reference line for us, and we go in 10 millimeter steps distally and proximally across this region here. And here you can see an example of inching when we are stimulating the nerve in 10 millimeter steps. You can see that the steps are very stable and increase linearly. If we superimpose these signals, you can see that the amplitude remains very nicely stable, and there's no prolongation of latencies across here. When we look at the reference values, this is from 64 elbows, and you can see that the latency here is on the average 0.2 milliseconds, But when we come to the segment just above the medial epicondyle, it's a little longer here. Which means that even in healthy subjects, there's a very small sign of wear and tear in this region where we see these temporary compression neuropathies. The amplitude doesn't change significantly, less than 5% change in amplitude from one side to the other. If we have a conduction velocity of 15 meters per second, that means the conduction time in 10 millimeter segments will be 0.2 milliseconds. And that's usually the conduction time we see when we do these studies. A conduction time of more than 0.5 milliseconds per segment is abnormal, and amplitude decay should be less than 5%. If we have temporary compression, usually the abnormality is above the medial epicondyle. Here we see subjects with retroepicondylar neuropathy, and it's very clearly proximal to the medial epicondyle. So it's this region right here where the problem is, above our reference line here. If we have a problem which is distal to the medial epicondyle in the cubital tunnel, now you see that here we have the epicondyle right here, and the problem is more distal to the epicondyle. So here the prolongation is located significantly more distally. We do the sensory nerve conduction studies as well. Here antidromically, you can do them orthodromically as well. And we measure the dorsal branch of the ulnar nerve, place the recording electrode between the metacarpals 4 and 5 and stimulate at the wrist, get a nice response. If we have an anomaly, we don't get this branch, and in that situation you need to stimulate the radial nerve as well. So you stimulate the radial sensory branch and you record from both the medial side where the radial nerve usually ends up and over the ulnar side where the dorsal branch is, and you can stimulate both sides. With the usual anatomy, you will be able, when you stimulate the radial nerve, you get the response over the radial side of the hand, but no response over the ulnar side. And when you stimulate the ulnar nerve, you get a response over the ulnar side, but not on the radial side. If you have an anomaly, you get no response when you stimulate the ulnar nerve, but you do get a response from both the ulnar and the radial side with stimulation of the radial nerve. Our protocol for ulnar neuropathies is we do ulnar motor, stimulate at wrist below elbow and above elbow, sensory, wrist to digits 4 and 5. If the site of the lesion is not obvious, we do the dorsal branch as well. If you have an ulnar neuropathy at the elbow, the dorsal branch will be affected to the same degree as the sensory branches to digit 4 and 5. But if you have a rarely occurring ulnar neuropathy at the wrist, the dorsal branch will be perfectly normal while the sensory branches to the digits are abnormal. Inching across the elbow is very helpful as well. We do the median nerve as well, motor and sensory. And if you have an abnormality on neurography in the symptomatic side. We also check for subclinical abnormalities in the contralateral side. EMG is usually a part of this study as well. You look at proximal and distal ulnar nerve muscles in the hand and in the forearm. C8 muscles in the radial nerve, extensor indicis, thenar muscles, flexor carpi radialis, triceps, biceps. Personally, if I have a clear-cut ulnar neuropathy that shows a focal abnormality in the elbow region, and it's a mild neuropathy like the previous case I showed previously, I may omit EMG if the neurography findings are unequivocal. So, in a mild neuropathy, EMG may be quite normal. Or we see slight abnormalities in the hand muscles, but flexor muscles in the forearm are normal. In a moderate neuropathy, we see mild abnormalities in the forearm, moderate abnormalities in the hand muscles. And if we have a severe neuropathy, we see a moderate abnormality in the forearm and severe abnormalities in the hand muscles. Differential diagnosis is very often quite obvious. Ulnar neuropathy causes clear-cut sensory symptoms, motor weakness. Usually, if it's an ulnar neuropathy at the wrist or at the elbow, it's not there's no pain. So C8 radiculopathy, very often you have severe pain if it's a lumbar disc herniation. Plexopathies, if you have Parsonage-Turner syndrome or you have a compressive neuropathy in the brachial plexus, very often you have pain. ALS that shows no sensory abnormalities. Syringomyelia may be a little bit tricky, but again, it's more widespread than ulnar neuropathy. Imaging studies are helpful. X-ray may be used to demonstrate arthrosis of the elbow. Ultrasound will show enlargement of the nerve at the elbow. I'm not really sure to what extent ultrasound can discriminate between different etiologies. MRI will show signal changes of the ulnar nerve as well. There is a recent expert consensus recommendation that was published in Clinical Neurophysiology 2021, a group of prominent clinical neurophysiologists doing both EMG and ultrasound. They found a consensus agreement, and what they came up with is that electrodiagnosis and ultrasound together are more informative than either modality alone. And EDX testing should always include nerve conduction studies, and ultrasound should include cross-sectional area measurement of the nerve at the elbow. So, some very clear-cut ideas here. So, let's look at the treatment. Successful treatment, that requires that we have an accurate diagnosis. We localize exactly where the problem is. We characterize the problem, how severe is it, and the pathophysiology. Is it axonal? Is it demyelination? Is there a conduction block? The pathophysiology will also help us to give a prognosis. If we have a pure conduction block without any axonal involvement, we know that once the compression has stopped, the nerve will recover within a few months. But if we have a severe axonal involvement, the axon has to re-innervate and grow back to their targets. That will take at least 7 to 12 months, so it's a much slower process. And we also need to identify the causal mechanism. How did the neuropathy come about? Unfortunately, we have very few studies where different etiologies have been separated from each other, but all ulnar neuropathies at the elbow have been lumped together. So we still have to use common sense until we get good studies where we differentiate these different etiologies. Here is a group of neurologists that have looked at ulnar neuropathy at the elbow, followed them up and looked at prognostic factors. There were 69 patients with 74 affected arms, again more men than women, and the more severely affected were treated surgically. And this was not the study that was designed to evaluate the optimal treatment. And the follow-up time was a little bit longer than 1 year. Some recovered completely, 12%, 28% improved, which means that quite a few ulnar neuropathies will remain with significant symptoms. And surgery was done to the more severely affected ones. And the ones with a conduction block and slow conduction velocity on neurography were the ones that had a favorable prognosis, indicating that probably these were caused by temporary compression and only with a demyelination and not much axonal involvement. And unfavorable prognosis, very large and thick ulnar nerves on the ultrasound. Luca Padua and his group looked at the natural history of ulnar entrapment at the elbow. Again, you see that there's no differentiation made between the different etiologies. All ulnar neuropathies at the elbow are lumped together. The number of patients was not impressively high, but you see that the ones with mild affection, many improved, some were unchanged, and some worsened. And the ones that were operated were the ones that were more severely involved, and some improved, quite a few improved. So if we look at conservative treatment, I think it's very important that we identify the etiology before we start our conservative management. And if we identify the reason, we explain it to the patient and we help the patient to avoid the static flexion of the elbow. And the patient will also need an idea of the time course of the recovery. The conduction block will usually recover within a few months, and the axonal involvement will take much longer, up to 1 year. And usually when I give the prognosis to the patient, I will be a little bit pessimistic. This way the patient will not get anxious if the neuropathy doesn't recover quickly. Splinting, there are no studies that would support using a splint. It reminds the patient of the problem, but splinting during the night in the elbow is quite uncomfortable, and many patients will not wear the brace during the night. Local steroid injection should be avoided. There is a danger that you may sever the nerve when you do the injections. If you follow conservative treatment, follow up the patient, and usually I like to see the patient for EMG about 4-5 months after the initial study to see that if there was a conduction block, it improved, and we may see axonal reinnervation in the flexor carpi ulnaris if the neuropathy was severe enough. Very often the patient will tell you that the sensation is unchanged. So the patient is not that reliable when it comes to the follow-up, so you really need the EMG here. And if there is no recovery in EMG, then we have to consider surgery. Surgery can be done in different ways. You can do in situ decompression, which means that you release the Osborn's ligament and flexor carpi ulnaris fascia. That's a relatively non-invasive procedure, very, very minor procedure actually. And if you have a clear-cut short segment study abnormality at this region in the cubital tunnel, this is probably recommendable. Another type of surgery that is done is ulnar nerve transposition. The transposition can be done to different degrees, and the nerve can be anchored in various ways. Here you can see that the nerve here is passing to the in the left picture here, ulnar nerve here, and when it has been transformed and fixed by the tendon here, passing in front of the epicondyle. Epicondylectomy is also a quite popular procedure, and it improves the pathway for the ulnar nerve at the elbow region. If you do epicondylectomy, you may get the problem with the antebrachymedialis neuropathy, and sometimes you see that the ulnar nerve is severed as well. So, surgical treatment, a tardy ulnar palsy, in my mind, should always be operated. It should be operated as early as possible. If you see tardy ulnar palsy late on with severe atrophy of the hand muscles, usually surgery will not give much recovery at all, so severe lesions are not worth operating. And entrapments in the cubital tunnel may be operated with release of flexor carpi ulnaris retinaculum alone. I think that most ulnar neuropathy should initially be treated conservatively, and if conservative treatment fails, we should consider a surgery. And we don't have any studies that would support and give indications for the best treatments of ulnar neuropathy at the elbow. We do not know when to treat conservatively or surgically. We have no studies that would separate these two. And simple decompressions and decompression with a transposition, they are equally effective. So let's look at the patient. This patient is referred from an orthopedic surgeon. It's a 73-year-old woman. She is right-handed, previously healthy, and for about a month before the EMG, she has increasing numbness of her left little finger. And the orthopedic surgeon is quite anxious to operate her, and he believes the ulnar neuropathy is at the wrist. Clinical findings, they show that she has reduced sensation over the ulnar side, both on the palmar and the dorsal side. And the little finger abduction is weak, but also the flexion of the little finger distal phalanx is very weak. The elbow is clinically normal. The sulcus is very nice. So very likely it's an ulnar neuropathy at the elbow. Wrist is very unlikely. We had weakness of the flexor digitorum profundus, and we had also this dorsal sensory branch affected. A C8 radiculopathy or lower trunk of the plexus is very unlikely. Here we see the neurography, motor median nerve, perfectly nice. Median sensory, little bit lowish conduction velocities, but still within the normal range. Here is ulnar motor, See very nice response stimulating at the wrist and at the below the elbow. There is no Martin Gruber to the hypothenar muscles. The amplitude change is 3%, but when we go above the elbow, there's a 98% decrease in the amplitude. Severe change. Sensory, nice responses, both at the wrist and, well, digit 5, a little bit slowish conduction velocity, slow normal. Ulnar nerve inching across the elbow, and you see that the abnormality is about 10 to 20 millimeters above the elbow, right, above the medial epicondyle. The epicondyle is right here. EMG shows reduced interference pattern in the ulnar innervated hand muscles and in the forearm, but no fibrillation potentials at all. So it's a pure conduction block in the retroepicondylar region. So it's about 10 to 20 millimeters above the medial epicondyle. The axonal involvement is minimal. Now, the interesting thing and the interesting part is, what is the etiology? And before her symptoms started, her favorite grandson had acquired her a computer equipped with Skype and Facebook, and she had 5 lovely grandchildren that were in touch with her on a daily basis. And she spent 1 to 2 hours daily on the computer in touch with her grandchildren. And this is the way she was sitting at the computer. So we had repeated static flexion of the elbow at prolonged periods of time. And once she stopped sitting with her and leaning on her elbow, she made spontaneous recovery in 3 months. So we have both Facebook and Skype to blame for this. The lesson we need to take here, that it's not enough to localize the neuropathy. You need also to find the cause. In this case, the orthopedic surgeon would have operated for sure the patient if we would not have found the reason for the neuropathy, and he would have been very happy with the result as well. So history is very helpful. Neurophysiology localizes the problem, but it does not give the etiology. The site of the neuropathy will suggest the etiology, but we do not have enough studies to really be sure of this. So most ulnar neuropathies are like this, caused by temporary compression. So we need more information on the causes of ulnar neuropathies and to what extent neurophysiology and ultrasound can help us differentiate the etiologies. And the prognosis and the treatment also depend on the etiology. Treatment. Conservative treatment. We need to help the patient to stop flexing the elbows statically. So we need to advise the patient carefully how he should use the arm. And surgery, which patient should be operated and what kind of surgery should be done. We need controlled studies for this. For the neurophysiologist, we need to localize the lesion and characterize the lesion. These are fairly straightforward and simple procedures. And we need to identify the cause. So it requires a little extra effort, detective skills. And while we do the measurements, we can talk with the patient and get an idea how the neuropathy came about. And we can give the patient also a prognosis. The conduction block will recover within a few months. no later than 3 to 4 months. Axonal reinnervation will take up to 1 year. In younger patients, the prognosis is usually better and the recovery is quicker than in old age person, and polyneuropathy, of course, is an issue here as well. So very often the static flexion of the elbow is the cause of the ulnar neuropathies. So prolonged thinking in this static position may be deleterious to your ulnar nerve. I wonder if Auguste Rodin's models that were sitting for him, whether they had an ulnar neuropathy at the end of the day. Thank you.